Hi, my name is Ty. I am a third year Doctor of Physical Therapy student at the University of New England, and this case report is about managing radiating hip and knee pain with hip mobilizations and strengthening. I would like to thank Dr. Jim Kavanaugh and Dr. Erin Pike for assistance with the construction of this case report. Osteoarthritis is the most common joint disorder in the United States. Knee osteoarthritis occurs in 10% men and 13% in women, aged 60 years or older. Some risk factors for osteoarthritis could include older age, sex, obesity, joint injuries, and repeated stress on the joint. Osteoarthritis can be conservatively managed with physical therapy, or if it is severe enough, surgery is an option. Hip instability is another condition that can affect the lower extremities and can range from subtle discomfort to a dramatic dislocation of the joint. Hip joint unsteadiness can present with or without pain. Unfortunately, there is limited research on treatment of hip instability and knee osteoarthritis regarding rehabilitation programs or strength programs. Therefore, the purpose of this case report was to utilize hip strengthening and mobilization interventions on a patient with hip instability and knee osteoarthritis. He was a 71-year-old Caucasian male, and his occupation was a carpenter and a farmer. He worked on his farm with his wife and milked goats to make cheese, yogurt, and other dairy products. He managed his chickens and built houses for a living. He reported that he regularly climbed up and down ladders during his work hours. He drove a large pickup truck that had a truck step bars for getting in and out of the truck. He had emergency cauda surgery and a lumbar decompression on L4 and L5 a little over a year ago. During the systems review, the only findings were low back pain with passive right hip extension and diminished patella and Achilles reflex. His posture was evaluated using a plumb line test, and it was found that the plumb line was moderately posterior to the hip joint, indicating that his pelvis was posteriorly tilted. The patient's lower extremity myotomes and gross strength were normal. As I said previously, his patella and Achilles tendon reflex were diminished. His lower extremities range of motion was normal. The straight leg raise and well leg raise tests were performed on the patient to rule out a herniated disc, and the flexion, adduction, and internal rotation test was used to rule out femoral acetabular impingement. These three tests were all negative. Posture, lower extremity, strength, reflexes, range of motion, special tests were unchanged at 4 weeks. The interventions that were implemented included manual therapy, soft tissue massage, and lower extremity strengthening as suggested by the orthopedic physician. Lateral hip distractions were performed on the first week of treatment and relieved the patient's pain immediately. This intervention was continued until the 5th week mark because it was found that posterior hip mobilizations were more specific for the patient's condition. Through clinical reasoning, it was thought that the patient's femoral head was irritating the femoral nerve. Therefore, hip flexor strengthening was also added to the plan of care due to the iliopsoas muscle group helping to resist anterior translation of the femoral head. The two functional outcome measures that were implemented included the lower extremity functional scale and the single limb stance test. The lower extremity functional scale improved from 47 points to 53 points out of a total of 80. He improved in the category of getting in and out of his car and his work activities. The patient's single limb stance improved from 7 seconds to 10 seconds on his right leg at 30 days re-examination. Although the patient showed relatively small improvements, he reported a reduction in difficulty and pain during his work and daily living activities throughout the 6-week rehabilitation process. The patient was educated on his posture and proper body mechanics, which may have contributed to his reduction in radiating hip and knee pain. Utilizing hip strengthening and mobilization interventions for treatment of hip instability and knee OA may have positive outcomes, but requires further investigation. Future research should focus on lower extremity strengthening and manual therapy for knee OA and hip instability. All right, that is my case report. Thank you for your time.